Yeah, good morning, everybody. Thank you for the introduction and for the invitation. It's great to be here in Rome with all of you. So, this is the title, Whether Properly Commissioned Delivery Techniques Will Render Routine Measurement PSQA Obsolete. So there are two keywords here, commissioning and measurement PSQA. Now, I'd like to start by clarifying that PSQA can be measurement-based or software-based. You could call it virtual as well, of course, as we discussed this morning. This can be independent dose calculation, log files, or other software analysis. And then PSQA can also refer to pre-treatment verifications or treatment verifications during treatment delivery. So that's also PSQA. But I'm going to focus mainly on pre-treatment measurements because that's what I think is obsolete or should be obsolete. But I will also mention a few things about treatment verifications, and we can discuss about everything at the end. So, we are here debating today because we have a problem. So let's start with the problem. I think that there are two main reasons for this problem. First is that errors persist as shown by external audits. These errors are not caught by local PSQA, and measurement-based PSQA is too often not sensitive or not reliable enough. And then the second reason is that pre-treatment measurements are not feasible, as you know, in online adaptive workflows. There are many, many references for this. I'm going to quickly go over a few of them, mainly from IROC, because I find them very clear, from the US. So in this paper, several years ago, they showed that measurement-based PSQA is not sensitive, it's not efficient, it's just not working. You see very poor sensitivity, smaller than 20%. They also showed that these errors are systematic, as you can see here, and they are typically associated with those calculations. So up to 68% of the failing irradiations of the IROC head and neck phantom were associated with calculation errors. So the problem typically comes from the TPS. Specifically, MLC modeling errors play an important role. They show that there are large differences in the MLC parameters used by the community, and they also provided a reference data set, which is very useful as a double check and for benchmarking. But we also have some good news, because they showed that a simple independent dose calculation clearly outperformed measurement-based IMRT QA, being up to 12 times more sensitive at detecting failures. And this is, of course, part of software-based PSQA, which can be more sensitive and obviously more efficient. So we already have important information about the keys to a solution. So we know that most errors are systematic, which means that they can and should be fixed through commissioning. And we know that software verifications are more sensitive and efficient, so they are essential. But we need to commission and standardize all the steps of the radiotherapy process. So this might seem obvious, but in my opinion, this is not typically the case. So I mean all the processes, not only the LINAC and the TPS, and this should include PSQA systems themselves, the PSQA workflow. So let's start with the commissioning of the PSQA verifications. So we have to commission PSQA systems, meaning also how we use them. So it's not only a device or even a system. And then we must compare with other detectors, an ion chamber, typically, to characterize their accuracy, and you need to understand the limitations of your PSQA systems. And there are two crucial steps here. One is the calibration of the system, and that's very easy to verify. You just need to create a reference beam, and then you follow the usual workflow as if it was an IMRT or VMAT plan. And then you should have a very good agreement. You see here in green in this part. Otherwise, it means that you have an issue with your calibration. And second, you need to evaluate the system's performance, mainly its sensitivity, meaning its capability to detect errors. And this depends on the device, on the software, because it's not only a device, that's why I call it a system, but also it depends on the metrics, on the acceptability criteria, the configuration, and the protocol you used, so on how you use the system. And I strongly recommend this paper that proposes a novel methodology for evaluating PSQA systems, mainly by introducing forced errors, quantifying the dose impact, and then evaluating if the PSQA system is able to identify those errors or not. Because, believe it or not, PSQA systems, the purpose of these systems is not to provide high gamma passing rates, it's to identify if plans fail or not, right? So the second point, maybe it's even more important, in my opinion, is that we must commission the treatment planning process. And by this, I don't mean the TPS, but how the TPS is used. So how treatment plans are optimized and evaluated. So I always like to ask this question. Do you think that you should measure this plan? Just think about a couple of seconds. It's a tricky question because that's not really a plan. So this is a dose distribution in the first place, and a treatment plan is much more than that. It's about the machine parameters to produce that dose distribution, right? So in the end, it depends on the plan characteristics. So to know that, you need to analyze the plan. You need information from the plan. You need to use metrics and software tools that are appropriate. For instance, you have here two plans. The plans at your left, it's a highly complex plan. The plan 2 at your right, it has a very low complexity, but the dose distribution is practically the same. You can evaluate using dose lines, DVHs, it's practically the same. But when you evaluate the plan, you see that plan 1 is much more complex, so it has a much smaller leaf pair opening or MLC gap. Modulation complexity score also lower, meaning high complexity, and plan irregularity, edge metric, MI total, all the metrics will tell you the same thing. Plan 1 is complex, plan 2 is not complex, meaning that plan 2 is a better plan because it has the same dose distribution but smaller uncertainties. But you need tools to evaluate this. So I will go over this very quickly, but plan complexity is related to accuracy, meaning that less complex plans tend to be more accurate. This doesn't mean that you will find clear correlations with your PSQA results. Likely, this is not going to be the case, and you shouldn't find clear correlations, actually. But highly complex plans are more variable, and then it's more likely that they fail. But plan complexity is clearly related to robustness. So that's clear. Less complex plans are more robust. More robust to what? To which uncertainties? Well, to all the uncertainties, to machine errors, to TPS modeling limitations, but also to patient setup or even intrafraction motion. And these are very nice references from last year about all these topics. So we need to evaluate and minimize plan complexity during treatment planning. By doing this, we will be consistent, there will be consistency in the plan parameters that we use, and this will improve accuracy and robustness and overall treatment plan quality. And this, interestingly, can be interpreted as plan QA, meaning that you are QAing the plan characteristics, which is software-based. Or it can also be interpreted as standardizing and commissioning the treatment planning process, which is a nice concept, not the TPS, but the process. And I have a remark here just to insist, it's not about finding correlations with PSQA results or even about predicting failures. So it's predictive QA, but what we really need to predict is that the plan will not fail. And then we don't need to measure. But if it could fail, then we measure. And then, because you define safe ranges for these plan parameters, meaning that you are safe within these ranges. But this doesn't mean that you are not safe outside these ranges. Okay, so treatment planning systems and QA platforms are progressively incorporating all these tools, which allows to optimize treatment planning and PSQA workflows. But there are many challenges, and because we need, for instance, standardizations and clear international recommendations, and we don't have them. That's why, just to let you know, there was an astrophysics workshop a year and a half ago, and there are ongoing working groups, and I hope that in the next few months we have some nice outcomes from these working groups. And I would also like to recommend you this publication from a couple of months ago, where we proposed 2 very nice metrics for this. This doesn't mean that they will show correlations with PSQA results, but they will tell you which plans are safe. So here's my proposal for treatment planning in 3 simple steps. You define class solutions, and the references from the NCS from the Netherlands are very nice. And then you need to incorporate complexity metrics and these plan parameters within the characterization of these class solutions. Then you validate these class solutions. How? Well, using measurements, of course. You do need measurements for that. And finally, you standardize your treatment planning using those class solutions and plan analysis. When you do that and you do treatment planning, the plan may fall outside a class solution. Then you try to bring it in by, adjusting the optimizer. But if you can't do that, then you need measurements and software verifications. And maybe you need more measurements because it's a challenging plan. But most of your clinical plans will be within a class solutions, will be typical. And in all those cases, you only need software-based verifications. Independent dose calculation, log file analysis, this will be enough. And you have a reference here from a few weeks ago where we published the national recommendations from Spain, where we further developed this proposal. So the proposed general workflow, and we can discuss about this later, is first commissioning. You need to commission the LINAC, the TPS, but also the treatment planning process, everything, all the steps. Next, standardization. You standardize your treatment planning. I think that's the missing link until you get consistent plan parameters. And then you do software-based PSQA mainly, and measurement pre-treatment PSQA only for those atypical or challenging plans. Then, if you do less PSQA, it means that machine QA it gets more important, so you need an enhanced LINAC QA. How can you do that? For instance, by including measurements of a fixed set of IMRT plans every 2 weeks or monthly, meaning that you evaluate a couple of representative plans or a fixed set of highly complex plans that allow you to verify that everything is in control, that everything is stable. But that's not PSQA. That's no longer PSQA. That's part of your QA program. That's machine QA, even if you're using the same system. And finally, you do treatment verifications. You do software verifications with log files, data integrity, measurements with transmission detectors, EPIT, transit dosimetry in vivo, and you verify your patients with imaging, IGRT, SGRT, independent dose calculations on CBCT, which is very promising, all these things. So just to illustrate it with a couple of images, you can do treatment planning without evaluating plan parameters, just taking a look at the dose distribution, at the dose on the screen. But then there's no consistency in your treatment plans. So you're not controlling that. So that's when, of course, you need measurements, pre-treatment measurements of all the plans, because you're not in control. Or you can control the plan parameters. Then you have your consistent, you reduce variability, you improve robustness, quality, and you don't really need PSQA measurements of all plans anymore, because that's part of QA. You move that to QA, which is, of course, much more efficient, because then the process is in control. So getting back to errors, it's important to think about what could go wrong and how could we identify that. So I recommend you this paper it's a recent paper from last year from a joint task group from AAPM and ESTRO, where we evaluated the performance of PSQA systems and talk about this topic. Mainly, it depends on you need to think about what could go wrong, which type of errors or categories of errors you could have. So first, there's the TPS-related errors, algorithm limitations, MLC modeling, whatever. For those, you need commissioning and QA. And you also need software tools to identify those challenging plans that might require more attention. Then you have Linux-related errors, and that's very simple, that's clear. You need commissioning and QA. And patient-related errors, meaning errors in the patient model that you use in the TPS. For those, you need IGRT, SGRT, and you can also use, of course, in vivo dosimetry or recalculation on CBCTs. And finally, you can have other errors, meaning prescription or plant quality, other types. For those, software tools are important, record and verify systems, scripts that you may run and define, etc. And then you might wonder, what's the role of measurements? Do we need to measure anything? Well, yeah, of course you need to measure. But measurements should be within commissioning and within QA, including the monitoring, the periodic QA of the class solutions. But measurement, pre-treatment, PSQA, that should only be for very specific cases requiring special attention. So, a few words about future outcomes. You all know the current guidelines, but there are working groups ongoing now from AAPM and Esther, for instance, this one. So we will have more documents in the future. We also have upcoming documents, for instance, this new GTV section from the Green Journal. It's a funny name because GTV stands for Green Technical Vision in this case. And it will be about pre-treatment PSQA, whether we need measurements or not. So this will be out in 1 or 2 months, I'm guessing. And there's an upcoming new point counterpoint from medical physics on this topic. So stay tuned. And that was my vision for enhancing and safety and advancing QA. So I'm looking forward to the discussion, and with this, I'd like to thank you for your attention.
Vision or my view on this topic. So, right, okay, let's get started. So Victor says it's all about definitions, and that's something that he started with, and I think he's completely right, of course. There was basically it's not PSQA, it's the pre-treatment routine-based QA that we want to discuss about, and I think that's an important point that he wants to make, and I'm completely agreeing. And there was this very nice debate at Estro, for those who were at Estro, and Victor made a really good stand against Nuria Jornet, both from Catalonia. And so basically, I just recycled Victor's cartoons because I like them very much. So these are the two standpoints. So one standpoint is it's a road full of dangers, and we as a physicist, we are blinded, we don't see the dangers, and we think that PSQA is our blind stock and it will help us, but it's a false sense of safety that we have. I like that cartoon, I like that point. And so the idea is that if you have class solutions and proper commissioning, you actually see what you're doing and you don't need the blind stock anymore, which makes sense. And then there's Nuria. She says, well, there's two kinds of physicists. PSQA is useless, so let's stop doing it altogether, because that's what Victor is saying. And she says, no, we can, if it's useless, it's not useless. If it doesn't work, maybe we should make it better instead of throwing it away. And I like that point too. So what's my point? Is it that simple? Actually, I don't think so. So let's make a step back. I'm going to play Victor for a few slides. So yes, PSQA, especially phantom-based pre-treatment QA, is just recommissioning over and over and over and over again. It's just testing your commissioning. And if you have done a proper commissioning, you won't see any errors in your patient-specific QA, or you have done your commissioning wrong. That's the point. Okay, that's the first point. Second point. If you do pre-treatment QA, especially the EPID-based one that we are doing, it's not sensitive enough. You've got all these false positives and false negatives. So it's the cry wolf story. You have all these false positives, and you have these red dots on your screen, and then you have to measure them and stuff like that. It's like this boy that was crying wolf somewhere in the Alps, and everyone was putting their sheep back in the stables because there was a wolf, but there was no wolf. And this boy does that 5 times in a row, and the 6th time there is a real wolf, and everyone says, yeah, there is the boy again with his cry wolf. We don't believe it, and there was a wolf, and the sheep were dead. And that's a problem. So that's the first one. The second one, it's difficult to interpret these data, especially the patient-specific QA, the perfraction 0, it's an integrated image. So if there's a failure in the integrated image, how do you interpret that? And now, of course, Avi, she's our champion on perfraction in my department. You all know Avi. She says, it's simple. I see it. If I see this thing, I know this is a breast swelling. We have to do something about it. I don't see that. I mean, I need Avi to do that. So it's really difficult for interpretation. And as Victor said, most of the errors are model-based errors. And I fully agree with that. I've used the same publications. I mean, it shows that with all the audits that have been done, the majority of the errors that have been seen in audits are based on bad commissioning of your system. So again, it points to the fact that we need to do proper commissioning. I fully agree. So, what's the solution? We need proper commissioning, and we need class solutions. That's Victor's point. We need robust plans. Class solution is maybe not the right word. It needs to be a robust plan. And so if you have positioning errors, we have SGRT, IGRT to cover that part. If there are mechanical and dosimetric errors, again, proper commissioning, you should be able to cover that part. If there are anatomical variations, there's dose tracking. So you can also cover that part. And of course, we have in vivo dosimetry. So in principle, we are covered. So Victor was looking in the wrong direction, but now he's looking in the right direction. So I'm using Barack Obama for a while. Mic drop, point made. Right, okay. Then this is me. Actually, that was me on Halloween, the left one, it's me. You don't recognize me. But I like this quote from the Joker. Nobody panics when things go according to plan, even if the plan is horrifying. And so you might have a very good plan, but are you really sure that everything is covered? So let's take a time out. So proper commissioning, class solutions, robust plans. There's a problem. How do you define complexity? I mean, these are all metrics that we have been evaluating in my department, trying to figure out how they can be used to actually define what is a complex plan. It's complicated. That's my first point. And actually, Victor is one of the authors in this paper talking about plan quality in radiotherapy, so he should know a lot about it. Second problem, there is almost no correlation between these metrics and failures. Like Victor says, it's not the point to actually correlate with failures in perfraction or something like that. You want to avoid that step. But still, we've been testing this also in my group, and we don't see any correlation with all the metrics that you've seen with failures in perfraction. So it's basically, and I borrowed that slide from Nuria in her presentation, it's like flipping a coin. You can use a metric, but it doesn't really say something. It's very difficult to use that, to know what metric is really relevant in what specific case. So let's look back, let's take a step back and look at the radiotherapy workflow. This is our workflow, from simulation, delineation, treatment planning, to QA, treating the patient, following the patient, in vivo dosimetry, going back in adaptive re-irradiation, these kind of things. And in the past, we've learned through mistakes that we need to define some safety barriers to make sure we don't make stupid mistakes. And once in a while, things go wrong. It's like the Swiss cheese story, you all know it. There are barriers in our safety nets, and if all these barriers align in a bad way, mistakes happen. We want to avoid these things. Enters adaptive radiotherapy. So we are pushed today to go into adaptive radiotherapy. Either it's offline, online, real-time. And so what is going to happen is that this flow is all in one, 10 minutes. What are we missing? And again, I got this Joker face on my head. It's like, we can try to plan everything, but are we really sure that we're covering everything? And then, and this is my really scary part, is that gentle pressure, and I put gentle between brackets, from companies, and the industry is not really helping us. Vendors are selling complex equipment as a plug-and-play. You can buy the ETOLs, and in 3 weeks' time, it's commissioned, and you can start treating patients in an online adaptive workflow. Your department is not ready for that. You don't have the procedures. People are not trained for that. And then there's the problem that the software is continuously upgraded. So things change constantly. So you can't really rely on the procedures that are in place and the things that you have tried to anticipate. And then, of course, there's AI and automation. And so tomorrow there will be an entire session on that. So I'm looking forward to see those presentations. This is a slide I borrowed from Ana Barragan Montero. It's already an old slide, it's 2022, but at that time, you don't have to read them, but all the green dots is where AI already has invaded in our workflow. And it's a black box, right? So with this large-scale introduction of AI and automation, we really start to rethink our role as humans in monitoring that process. And that's going to be the big challenge. And I've just reread the book. It's really scary because the book was written somewhere in the early 60s, 2001: Space Odyssey. But I see Dave every day now. Not Dave, but HAL. So HAL 9000, you know the computer, HAL 9000, Space Odyssey 2001. So he says, like, I'm sorry, Dave, I'm afraid I can't do that for you. And then Dave dies. Right. Good. So, as Patricia already mentioned, the aim of what we're doing is to really make sure that the correct tissue is treated in the correct patient with the correct dose, and this for every treatment session. And this in a very complex setting. So, I feel like Homer. I think we all do. Okay? Good. So, then you can say, and again, going back to the Joker that I mentioned before, but yeah, also the presentation that Victor showed from the group of the AAPM is we need to anticipate what's going to happen. What kind of errors do we anticipate? And that's where we have the FMEA. So FMEA is the solution because then we can look at what can go wrong in the department or in the process, and then we can start to try to avoid those errors with commissioning and class solutions and things like that. But then, well, radiotherapy is much more than a machine. It's not just a machine that goes ping. There's a patient, there's a lot of people running around, and they may make mistakes. They haven't slept for a few days, stuff like that. So is it that simple? Well, no. And again, I'd like to relate to some very interesting papers from Todd Pavlicki and Lawrence Wong, showing that the radiotherapy flow is not a linear thing. FMEA assumes that you go from simulation to treatment, and you look at all the different steps in a linear way, and you try to see where things can go wrong, and you try to look at those nodes and try to see what is a risk and what is not a risk, and can we avoid them, yes or no, looking at it in a linear way. But it's not linear, it's complex. It's like this Escher painting. And actually, this comes from the paper of Wong and Pavlicki. So we have to deal with complex systems. And these systems can only be understood if we know all the aspects, including the technical and non-technical issues that are related to that. And so it's the interactions of all these different system components that make things complicated. And it's such a complex thing that it's very difficult to really anticipate all the things that might go wrong. And so, going back to the quote of Patricia, it comes from Yogi Berra, famous baseball player from the New York Yankees many years ago. If you don't know where you're going, and I'm from Belgium, I like cartoons, especially the Belgian cartoons. This is my hero, Gaston Lagaffe. He's in all my presentations. So if you don't know where you're going, you might not get there. So that's the point I'd like to make. So what do we really need? Well, yes, we need to evaluate and validate and monitor the entire treatment chain. We need to detect and avoid catastrophic events, and that's the scary part. When things go wrong, it's not just one thing that goes wrong, one thing you can identify. It's usually a combination, it's a bad mixture of small errors that just add up in this catastrophic event. Look at the New York accident in, what was it, 5, 6 years ago? No, longer, 2007, something like that. That's the one you want to avoid. And you can't predict that. That was unpredictable. That's the problem. Most of these errors are not something that you really predict, because if you would have predicted it, you could have avoided it. That's the point. And so patient QA is there to actually monitor the entire treatment chain, or the pre-treatment QA, if I should say it like that. The idea is to detect these catastrophic events. It also stimulates quality improvement, because you're constantly measuring what you're doing. It gives you an idea of how can we improve things, and it introduces these sufficient safety layers that I was mentioning about, the Swiss cheese thing. And so we need to realize that radiotherapy is complex. So we need rigorous commissioning, but we need to know that this rigorous commissioning cannot predict every situation. And that's my main point. That's why we need patient-specific pre-treatment QA. So again, if we want to ensure that what has been planned really can be delivered for every patient, every fraction in a safe way, we need to think differently. And Victor has mentioned that already a little bit, and Patricia also actually, is we need to really start to think process-oriented. And we need these self-correcting mechanisms, especially when we're going to work with AI and automation. These systems need to be self-correcting. We can't do that anymore. It's becoming too complex. But there's a small problem, of course. It's a long road. So we need nonlinear system engineering. That's actually what Pavlicki and Wong are saying in their papers. We need checks and balances. We need fast, independent secondary segmentation checks, secondary dose calculation checks, and secondary data transfer checks. But they need to be fast, because we want to treat a patient, everything done in 10 minutes. And so we need statistical process control, fast and real-time predictive in vivo dosimetry. So when the patient is being treated, the in vivo dosimetry starts to measure and starts to predict whether or not the treatment is going the way we planned it to do it, because we're hypofractionating the patient and we're treating it in 10 minutes. So we really need in vivo dosimetry systems that are doing something while we're treating the patient, not afterwards, because in many cases it will be too late. So this is my point. It's doomsday, because it's happening today. We got these machines. Ethos is being sold all over the place. I mean, people are treating patients in 10 minutes, but their workflows are not adapted to it, and they don't have the proper QA tools as we speak. And so brings me to a very famous quote from my father, my late father. He always told me, never sell your old shoes before you got your new shoes, because you might end up barefoot. And that's my main point. So I agree with Victor, but we are not ready there. We're not ready yet. But at the same time, we are treating our patients. So as long as we don't have our new shoes, as long as we haven't figured it out, I will be more comfortable doing the pre-treatment patient-specific QA, because I know that I haven't covered everything at this stage. So I know where we want to go, so maybe I should change the t-shirt. We know where we want to go, but we're not there yet. It's a long road, and I think that's my last point. So thank you very much.
Now we both.
Oh yeah, now we have to rebuttal,
both
right?
stay.
Yes.
No, you can stay. I mean, so as you see, we agree in many things. I agree with Dirk about many things. Probably we could agree even in more things if this wasn't a debate, but it is. I also like this message, but he's the one wearing the T-shirt, not me. So, of course, we need to verify the dose, the correct dose is given to the patient, to the correct patient, every single fraction, of course. And then what's the point of pre-treatment verification to a phantom before the patient treatment? Because it doesn't really make sense. I mean, that's not patient safety. Maybe it's phantom safety. It's not patient safety. That's why we need to do treatment verifications, and we need to make sure that our plans are accurate and robust. But then you can verify it in every single fraction. But before the treatment, no, that's just commissioning. So, I mean, this probably made sense 20 years ago, 30 years ago. I'm not sure about 10 years ago, But now, I don't think it makes sense. So do you verify the PDD for every treatment plan? No, you don't, because it wouldn't make sense. Why do you verify this pre-treatment to a phantom for every plan? Well, that's because you don't trust your TPS or your machine to be able to deliver that plan accurately. That's because you know nothing about the plan. But the simple plans, you don't need to do that. Typical plans, you don't need to do that. I mean, it's not feasible for online adaptive. You were saying the same thing. You need to do that for every treatment fraction. We all agree. So we must do differently. We must do better.
Yeah. Again, this works if the flow goes according to plan. As long as I'm not convinced that we can avoid, and I think the New York accident is it's not a nice example, it's a very strong example of things that were not anticipated. And the fact that it happened is also that because of the fact that the people were under stress, the patient needed a replan, it was done at the last moment, so because of that they didn't do the pre-treatment QA, and they missed the fact that the MLC data was not transferred to the machine, so they treated the patient with an IMRT IMRT setup, but without the IMRT part, so the MLC was not, and they could have, I don't say they should have, I'm not blaming anyone, on the contrary, I hate the blaming part. But they would have seen it if they would have done a pre-treatment QA, making sure that the transfer of the data did not go wrong. Of course, they could have seen it before because there was a crash in the system during the data transfer, but still, they didn't. And it just shows that unpredictable things happen. It's like skydiving. When I was young, I did a little skydiving. I was crazy at that time. But most of the time, you spend the time in really folding the parachute, making sure that when you open it, it will open. And it takes half an hour to really fold it meticulously to make sure it will open. But I've never seen a skydiver jumping without a backup, without a reserve parachute, because sometimes it goes wrong, and then you want this backup. And for me, at this moment, patient-specific pre-treatment QA is my backup at the moment, until we have a solution that is more or less watertight. But at this moment, it is not watertight. So I don't feel comfortable going to bed in the evening knowing that maybe something like the New York accident slipped through the mazes of the system. And that's my scary part. So.
Yeah, but it's a sense of safety. It's not real safety. So you can easily verify the data transfer
It's one of the safety layers. Yeah. But if we take it away, we need to be sure that the things that we could have tested with that safety layer, we test it in another way. And I'm not sure we are quite there yet. That's my scary thought.
Yeah. But I agree that we need to do this FMEA analysis, I mean, prospective analysis, risk analysis, because that's when you will see where it's most important to put the effort and to, really introduce barriers and improve safety. And yeah.
But I think we agree. I mean, the future is, and it's also what Patricia said, the future is really in rethinking what we're doing today. We can't keep on doing what we did 20 years ago. That's stupid. Because, and like AI and automation, it's like a tsunami coming over us, and we are not prepared for it. We have to step back a little bit and think, how can we rethink the QA of the process? And that's the challenging part.
So we can agree that it's about the process every time more and more. So we need to think about SPC and about how to better monitor all these processes to really advance QA and improve safety, patient safety.
And I think that's also a message to the people of Sant. Like the new machine, the new daily QA that's presented, it's all very nice, but it's checking a small part. We need QA tools that are monitoring the process. So we have to focus on the process part. And I think that's going to be a big challenge. So yeah, I think in that way, we completely agree, I guess.